A 28-year-old man presented with two symptoms that appeared entirely disconnected. For 8 years, he had suffered from chronic diarrhea triggered by wheat ingestion. Now he had developed a deep, non-healing ulcer on the sole of his right foot. Medical teams initially viewed these issues in isolation. The gastrointestinal distress was treated as standard chronic enteritis, while the foot wound was diagnosed as a stubborn but localized bacterial infection. The patient received broad-spectrum antibiotics, intensive wound care, and systemic corticosteroids. Doctors were treating the symptoms as individual problems rather than signs of a single, larger process. This lack of response marked the beginning of a 19-month physical decline that would eventually lead to the loss of his limbs and his life. While the medical focus remained entirely on the skin, an aggressive malignancy was already expanding through his system. When chronic symptoms affecting different organ systems are treated as separate events, systemic diseases can easily be mistaken for localized infections. 1 year into his treatment, the patient's condition took a turn towards systemic collapse. He was admitted to the hospital with a fever of 40.7 degrees Celsius and significant rapid weight loss. His laboratory results reflected the severity of this decline. His albumin levels, a key marker of nutrition and protein retention, had dropped to a critical 16.4 grams per liter. This indicated that his gut was no longer absorbing or retaining protein. As his internal health failed, new necrotic lesions erupted symmetrically on his right hand and left thigh. Multiple skin biopsies were taken, but they were too superficial, capturing only the dead top layer of tissue and returning nonspecific necrosis. Even though a localized bacterial infection rarely presents in a perfectly symmetrical pattern across the body, the medical team continued to escalate antimicrobial therapies based on their initial diagnosis. Relying on shallow biopsies while a pattern of tissue death expands across the body can trap clinicians in a diagnostic loop where the true cause remains unsampled. In an attempt to stop the spread of the necrotic tissue, surgeons performed a life-altering intervention: the amputation of the patient's right hand and his right lower leg. While the surgery removed the dying tissue, the disease driving the necrosis remained in the patient's system. The primary source of the illness was still active and untreated. 1 month after the amputations, the patient developed an acute abdomen, requiring an emergency exploratory laparotomy for a suspected bowel perforation. During the procedure, surgeons found a massive tumor in the jejunum that had perforated the intestinal wall. Pathology results from the intestinal mass provided the definitive diagnosis: Enteropathy-Associated T-cell lymphoma, or EATL type 1. This is a rare, aggressive cancer that originates from the immune cells in the gut. The discovery came too late. 3 weeks after the surgery, the patient died of multi-organ failure. Addressing the localized symptoms of a systemic disease without identifying the underlying malignancy eventually leads to the collapse of the body's major systems. This 19-month delay illustrates how a condition with a clear clinical history can be overlooked when its presentation is atypical. The first pitfall was a persistent focus on infection. This prevented the team from considering a systemic malignancy, even when the patient failed to respond to every antibiotic regimen they prescribed. The patient's 8-year history of wheat-sensitive diarrhea was the key. This strongly suggests undiagnosed celiac disease, a condition where chronic intestinal inflammation eventually triggers the malignant mutations that cause EATL. The third failure was the reliance on superficial skin biopsies. These samples only contained the necrotic debris at the surface, failing to reach the deeper layers where the lymphomatous cells were actually located. Finally, the care was fragmented. Because the skin ulcers and the gastrointestinal symptoms were treated by different specialties, the two were never integrated into a single clinical picture. The case proves refractory skin ulcers can be the first presenting sign of an occult lymphoma. When common treatments fail, clinicians must perform deep, full-thickness biopsies of the lesion's active margins. As the conclusion states, when common diagnoses fail and disease progression defies expectations, physicians must look deeper. Early recognition and multidisciplinary thinking can be life-saving. Multidisciplinary evaluation is more than a best practice. It is a clinical safety net. Integrating seemingly unrelated symptoms is often the only way to identify an aggressive systemic disease before it becomes fatal.